Hello, everyone. Thank you for joining this webinar dedicated about practical session on lower limbs. So we will discuss this today. Just a quick comment regarding the last webinar, the first webinar we did on the 21st of June. We were a little bit late and we apologize for that because we were just waiting for the audience to come in. So thank you again for joining us today for this practical session. My name is Mary-Christine Collette. I'm an education specialist representing the interest of the Swiss Doloclast Academy, the training organization which has been created by the Swiss company EMS, Electromedical Systems, who created in the early 2000s the Swiss Doloclast method. So today we will be discussing a practical session. First, a quick introduction on theory and then move to the hands-on side and offer you tips and tricks for the daily practice on lower limbs. So we are happy today to welcome again our two of our greatest experts on the guided Doloclast therapy, two experts from Germany, Peter Stiller and Alexander Ablas. Thank you both for being with us again today. So Peter and Alex are specialists in the guided Doloclast therapy, which is a holistic treatment concept including radial and focused shockwave therapy, laser technique, and also rehabilitation techniques and exercising. So just a few technical points before starting this amazing webinar. As you can see on your screen, you have a chat and Q&A icons on your screen. Please feel free to use them to ask your questions, and we'll be using them and answer them after the session. So thank you again for your participation. And I also thank A-Medic, our Japanese distributor representing the Doloclast locally in Japan. So thank you for their collaboration. And we hope you enjoy this session. Thank you. Off you go, Alex and Peter.
Okay, so we start. Wait a second. Okay, so hello to everybody, to all participants. We're very proud and happy that you are here. I hope that everybody can see the slides now. We'll start right away with the new theme of this second webinar, lower limb. Let me say a few sentences as a summary of the last webinar concerning the theory of radio shockwave treatment. Very, very short. I do this in about 10 minutes, and then you will see a lot of cases. The cases are, most of them, indications that I think everybody knows. Some of them are off-label, but we will tell you when this is the case, because we think we will give you an overview of what you can do with shockwave and what are the classics of indication. First of all, what is the aim of modern shockwave? This is very important, and this is the only slide that I will go through completely. We want less medication, we want less injections, less operations, of course, and we want to work non-invasive with very low risk level and high effective. And high effective is really high effective means that Alex and me are doing our shockwave, I would say 90 to 95% with a really good success, and the patients are very happy with this. So, next one. When you talk about evidence-based medicine, we have shortly to talk about Christoph Smets. He's one of the 2 or 3 most famous scientists concerning shockwave therapy, laser therapy, and stem cell therapy. All we know and all we can show you from the scientific side and the evidence-based side is all gone through his head and his hands. That's why This is the next one. That's why radial shockwave therapy with EMS is evidence-based, because he's working for that the last 20 years. How we are talking about radial shockwave, how does it work? How's the generation? It's a ballistic generation, means compressed air goes accelerates a projectile up to 90 kilometers per hour with very high speed. Then it hits or strikes an applicator, and at the front point of the applicator you can see the wave that's going out there, and the black dots, the so-called cavitation bubbles, and very, very important. As you can see here, in the negative phase, we have a positive phase, as you can see, very high power, very high pressure. And the negative phase gives you the cavitation bubbles. Cavitation bubbles are imploding after the wave ended. And then they are hit by the secondary shock waves, and they bring the whole energy of the cavitation bubbles as a jet stream into the tissue. That's how it works and why it works so good. And now, very short, you can see the difference between, for example, the EMS device or STORZ or BTL, because if you take these three, the EMS-E is the Evo Blue handpiece. It's the same handpiece we use and you use with your Smart 20. And if you go on 4-bar with 15 Hertz, you can see a lot of bubbles with the EMS device and less bubbles with BTL or STORZ. Even if they can do 5-bar sometimes, the cavitation bubbles that are important for your success in your treatment are less. And if you see what the computer counts, the computer can count every single bubble, then it is much more impressive what you can do with an EMS device and BTL or STORZ. So there's no discussion which is the best device to work with, and the best device was the most success on the market. This is only to show you why you always see a red chili pepper, because red chili pepper contains capsaicin. Capsaicin works on the so-called C nerve fibers that are important for the pain that you can feel then, and for the neurogenic inflammation. Capsaicin can activate the fibers so that the depots of substance P is important for feeling the pain, and then for the neurogenic inflammation, goes up for a few seconds, and then if you bite on the red chili pepper, sometimes it goes down and you cannot feel the pain anymore. That's exactly the same that happens with shockwave. It's an activation of the C nerve fibers. If you do it a few times longer, then you see on the patient's face that the pain is going away, and that's what we want, because then the pain goes down, the neurogenic inflammation goes down, and then we get 2 additional effects. When the neurogenic inflammation goes down and growth factors are released and stem cells are activated, or sclerexis, which is a transforming factor for the tenocytes that you find in tendons and ligaments. If they go up, the tendons can grow. And if you combine all this together, you get real healing. And that's what we want to do. We are talking about regenerative medicine that we do, or regenerative therapy that we do with radial shockwave. Don't use it with local anesthesia, because local anesthesia blocks the effect that I explained before. That's very, very important. Never use local anesthesia when you work with your shockwave. For us, very important is that lubricin, which is the gliding stuff in tendons and tendon skin, is only produced when you are moving the tendon or when you use shockwave. Shockwave is the only treatment option to bring lubricin into the gliding skin or tendon skin that we need. So that's why we use it, for example, also post-operative in the first days. Very, very important. Indications, very short, you know the classics, of course, the calcified shoulder, Achilles tendon, tennis elbow, and so on. These are also approved indications for the Swiss dollar class. As you see, trigger points, lymphedema, we'll see some of them today. The greater trochanteric pain syndrome, Osgood-Schlatter disease, stress syndrome at the medial tibial, wound management, for example, and we'll show you some cases now for all this. These are, I would say, modern or new indications, and a lot of them off-label indications. That's why I don't go through all of them. If you have any questions, you can also ask us after the session or send us an email. It's no problem. We'll give you all information that you need if you want to treat some of these indications. And the contraindications, I just put it in there that you have the slide, but we'll not go through all of them now. These are the contraindications that you can read on the AMS device. So, and what Marie-Christine told you, we are doing the guided dollar cloth therapy. That means that we bring our, as you see here, we bring our knowledge and all our experience and skills into it and combine it with the laser therapy that is new now from EMS and the radial shockwave therapy. And we also do in Germany the focused shockwave therapy. But the most important of all is, of course, the radial shockwave therapy that you can do with your Smart 20 or we with our dollar clasp. And if you want to do this, if this comes to Japan, we'll give you all our knowledge and all support that you need to do this also. Okay, that's it. Very short, the summary of the theory. Now we go into the cases, and the first case is the patella tip syndrome, and Alex will do this.
Hello from my side. We prepared a lot of cases from the top to the bottom of the lower limb, just to give you an overview about what is possible. One of the most common indications we really have very often in our clinics is patella tip syndrome. This is the case of a 46-year-old former football player in Germany, also marathon runner. He stopped playing football years ago because of persistent knee pain. In the MRI 3 months ago, we could see a clear picture of a severe patella tip syndrome. The former treatments, this is very common. What these patients tell you, they tried a lot of medics like NSAIDs, local cortisone injections, and all this stuff, did physio, X-ray irradiation, pain acupuncture. They tried a lot, but still suffering from pain. All these things had a short time improvement of pain, so we started to do the shockwave. As you can see on the pictures, is the way we do the shockwave on the knee. The first treatment started with 0.3 bar with a 15mm applicator, a frequency of 20 Hertz and approximately 4,000 impulses. We increased over the second and the third treatment up to 2.4 bar, the same applicator, same frequency, and always 4,000 impulses. The result after 3 treatments, so after 11 days in total, he was completely pain-free in everyday life, had a completely normal range of motion, started running again. Pain starts after 30 minutes, but very less, just 4 out of 10. Then after 2 further treatments, he was completely pain-free in a 19-minute run with good training speed. So the end of treatment was reached after 7 sessions in total.
So then the second case is so-called osteochondrosis dissecans, means there is a maybe traumatic or sometimes even without any trauma, a problem with the cartilage on the bone, means the cartilage goes up from the bone. Sometimes you can also see a flap there. That's very, very painful. And now we chose one of the ankle joint. You can also see this in the knee, for example. In this case, it's a 56-year-old female patient. She had the same problem on the other side, had an operation because in Germany, it's a pity, but they very often do surgery on this. She had no success from the surgery. It was terrible. And 1 year later, she got the same thing on the other side, on the other ankle, and she had pain all day, was crying when she came to my practice. She couldn't stand or walk long. And you see now the picture before the treatment. And the next picture is also before the treatment, very important because she had a long rest of several weeks. She didn't put pressure on the ankle, but the picture went worse and worse. So this is still before the treatment. And you can see after several weeks of rest, the findings were consistent or even worse. And the pain was became very strong. So she said the pain got worse and worse during the time of the rest. So we had to do something, and we started with shockwave therapy in this case, because with the focused shockwave, you can point on this little area where it takes place. We did radial and a little bit of focus too, but you can also do it with the normal radial shockwave on its own. They always get vitamin D3 for the bone, of course, cooling bandages and insoles for a better cushioning of the whole foot. And she was pain-free for the first time after 4 weeks. We had the frequency of 1 treatment per week. And after 4 treatments, 4 weeks, she was pain-free in her normal day life and during her work. Then we went down to 1 treatment per month. And now for the last, I would say, 2.5 years, we're doing this every 6 to 8 weeks. So they only have to come every 6 weeks to have a perfect result and no pain. And then she had she was pain-free in doing everything that she normally does when working or in her daily life. And then she had 2 MRI checks, 2 MRI controls, one after 3.5 months. And now you can see that, I show you the last one. You see that it is much smaller now, the area here, and the pain is gone completely. As you can see, improved compared to the previous examination. That's what we want to see after 2.5 months, I think it is. After 2.5 months, this is, or 3.5 months, this is really a good result. But the patient was funny because she went to a new control MRI without telling me anything. 3.5 years after that. And now I show you the videos, both. And in the videos, you can see that there's nearly nothing to see anymore because the osteochondrosis dissecans is consolidated, something that you normally learn that this is not possible. But you can see there's nearly nothing to see anymore, and she's still pain-free. I told her after the MRI she shouldn't come anymore because it is gone, but she's so happy that she's pain-free that she comes every 8 weeks for the whole future, I think. The next one is to show the lymphedema problems that some guys have in their arms, or in this case in their legs, because of tumors or any trauma they had. And this is a very, very massive lymphedema, and a 58-year-old patient with a malignant chondrosarcoma in his knee and in his right abdomen. He had or a lot of series of irradiation. You will see the pictures in the next slide. And he had a unbelievable massive swelling of the leg. As you can see here, it's 74 centimeters circumference, but it is 3 centimeters suprapatellar, means not the biggest part of his thigh, but it's nearly over the knee. So 74 centimeter means this. And if you compare this to the other leg, he has normally has thin legs. And if you compare this and see what the irradiation did with the knee, that's really terrible. I go back to the last slide to show you. They told him to amputate the thigh, but the patient said, no, you cannot do surgery on my other chondrosarcoma, so I don't want the amputation. But he had lymphatic drainage 4 times a week, 90 minutes, very, very intensive lymphatic drainage. But as you can see, it worked only to this point. And as you can see, there were a lot of wounds coming up from time to time because this skin was very thin after the irradiation. And that was one of the biggest problems. He had always pain. He had this fibrosis. his grotesque swelling. As you can see here, the calf was 56 centimeters. That's unbelievable. The ankle was 31. The foot was 31 on the middle foot. That's really a lot. So he couldn't move his knee to 20 degrees. Maximum knee flexion is nearly nothing. And he had a tibial nerve damage and, of course, psychological impact. We started to treat him with only 1.5 bar. I always do the whole leg, starting from the middle foot and going over the whole leg after releasing the whole leg. We tried to increase the load, but 1.5 bar being was okay. And as you can see here, it got better. So the feeling got better for the patient after 3 treatments. After 5 treatments, he could sleep for 6 hours in a row, which was not possible for a month and months before, because the pain was much better. After 15 treatments, he could stand on his toes with this leg. And after, I think we are at 9 months or 8 months, it was possible to get the swelling under control after a long standing, the swelling under control by going for a walk. So the muscle pumps in his legs started again. So we are sure that he got a new lymphatic system in his leg, and this was only the result of the shockwave therapy. And today, as you can see now, it's nearly unbelievable, but we are really with 44, and at the bottom is an old one with 47 centimeters. Now we are at 44 centimeters. The knee flexions improved from only 20 degrees to 100 degrees, as you can see on the right picture. And the knee tumor, I was always asked about the tumor. We know that this is normally a contraindication, but in this case, with the patient suffering so hard, and he said, do whatever you want, but I cannot live on with this leg. And so everybody asked, what about the knee tumor? And the knee tumor was 2 centimeters smaller in the MRI control. And we had no further spreading of the tumor until now. Change again.
One of my favorite cases concerning fractures. Yeah, I choose Jones fractures as a topic of healing bones. Yeah, but you can do it on all other bones too. So we do the Jones fracture example now. This was an under-19th national team soccer player. During a football game, he was suffering from a distortions trauma on the right midfoot. As you can see on the X-ray pictures on the left side, you see the fracture line of with a little dislocation after surgery with a screw, reposition, minimal invasive, which is very good for treatment with shockwave afterwards, because the wave is reaching the fractured area from all sides. So if possible, don't use a metal plate for this. Then we start with the treatment directly on day 2. The first day he was in hospital, getting manual lymphatic drainage, several cooling devices on the foot. And on day 2 and 3, we already started with the radial shockwave for lymphatic drainage, thereby using the 36 millimeter applicator, very low pressure, 1.5 to 2 bar, which is quite comfortable for the player. Approximately 3,000 shots with a frequency of 20 Hertz. Afterwards, we always use a special kind of cooling device like cryolite, hyperbaric CO2, but also every kind of icing is good. From day 4 onwards, we apply daily radial shockwave with a full contact on the fracture by using the big applicator, 36 millimeters, reaching the threshold of the patient. Don't worry about using shockwave while still stitches in the wound. You will see later a case with an open wound on the leg. This is no problem. You can use sterile foil or disinfection fluid for going on the skin. From day 11 onwards, we do daily radial shockwave, even using the 15mm applicator to get as much power on the fractured area. The good results you can already see after a short period of 4 weeks. Yeah, the players are completely pain-free, no swelling, and always want to already start walking normal. So he was still wearing an Airwalker shoe, as you can see on the left 2 pictures, with full body weight on the foot. The fracture is already started to close, so we allowed the player to start cycling without the Airwalker. We had a full range of motion. After another control X-ray after 6 weeks, you can see that the fracture is better than 2 weeks before. He already starts training with the ball. He could increase running. In the follow-up, we applied daily radial shockwave on the fractured area to decrease the refracture rate. The player starts team training after week 11 and did his first season game after 13 weeks. In this table, I just want to show you that this was not just a single case. This is a comparison of 3 Jones fractures, which we were treating just like the same you saw before. And as you can see in line number 3, return to competition, almost all these Jones fractures reaching the same amount of days. If you compare, especially with this kind of fracture, which could have a really bad healing rate, this is just 2 famous cases in Europe about what really can happen if you don't treat properly. This was a famous football player in France, suffering from a Jones fracture, needed more than 90 days to recover. Or one of the most horrible cases of a Jones fracture with a refracture rate was more than 289 days in total. So radial shockwave is a brilliant possibility to treat bone fractures of all kinds. The second one, kind of a muscle injury. Just as an example for treating all kinds of muscle injuries, this was a strong myoglosis of the gastrocnemius muscle directly before a league game. Therefore, I also want to emphasize that using shockwave directly for a game or a match, for example, is not a problem at all. The player comes to the medical staff room directly before warming up before the match. He said that he was not able to play because of severe pain in the gastrocnemius muscle. We found a very hardened gastrocnemius muscle right side with painful knots. He also felt this a bit during training during the week, but it was not that painful. So we started with a radial shockwave immediately after doing an ultrasound, because we just wanted to check that there's no injury which can increase during the game. Then because of no injury, you can reach high pressure on the muscle area. So we already started 3.0 and 3.5 bar, big applicator, high frequency, a lot of impulses, 5,000 on the gastrocnemius muscle. The result was that he was feeling much better immediately after the treatment. He could do the warming up. After the warming up, we did another 1,500 impulses on the same area, and it was no issue anymore. He played the whole time of 96 minutes, including the overtime, in a very intensive match without any problems. And lucky ones, they won the game too. So this is a very brilliant thing to treat. On the pictures, you can see the way we are treating it. If there are questions about it, we can do it live later, how to treat muscle area with the feeling. But this is the way we treat gastrocnemius muscle.
So the next case is again something about the bone. In this case, a bone marrow edema, because I think this is really important. We have a lot of these kinds of cases, especially when we treat sportsmen. In this case, it's a 26-year-old football player of the third league in Germany. It's high enough. I think he knows how to play football. And he did a little bad movement when he was playing in an indoor tournament in January. Not a really hard trauma, but a little movement to the side. And he said, "Oh, now I feel some pain." Then they told him not to do any indoor sport anymore. He had sports abstinence, had physiotherapy, pain medication, of course, ultrasound, acupuncture, and so on, but there was no improvement. And we were talking about January. Then they tried it 2 months. And the 3rd of March, they did an MRI and they saw a bone marrow edema, the attachment of the anterior cruciate ligament without any injury of the ligament itself. That's very important. There was no ligament rupture. I show you the picture first. This is the bone marrow edema. The area that you see here in white shouldn't be there normally. This is really can be really a painful area, as the guy told us, for 2 months. Then they knew what happened, and they knew what is the problem. Did the same treatments again for the next weeks. And at the 5th of May, when the pain was still increasing, not decreasing, but increasing, he came to me, and the clinical findings. And during physio, had so much pain that the physio couldn't go further with him. And the range of motion, which is very important for a football player, of course, was 20 degrees less in bending and 10 degrees less in stretching, which is severe for a football player. And when you're talking about May in Germany, that's the time when they are back into their normal season, because the weather is better and they are back into the season. And he couldn't start, he couldn't do anything. And so when he came to me, the knee was completely stable, but the anterior draw test hurt him a lot. And he had no pathologies of the patella, but he couldn't bend or stretch the knee right. So that's what I showed you before. So what did we do? In this case, you can also do it only with radial shockwave. We did it with radial and focus because we could reach the point where it comes from very well. So we combined it, but you can also target on the bone marrow edema only with radial. And we work always on the tendons too, because in this case, the bending and the stretching of the knee was decreased. So and was not so good as he should be. So we worked on the bone marrow edema and the tendons and the muscles that are surrounding the knee. After 3 shockwaves, he had no pain during his everyday life, which was the first time for the last over 4 months. And we could go on 2.7 bar and intensity 4 on focus. That's a lot. And he started cycling, cross trainer, and the range of motion was normal after 3 treatments. That's very, very important. By using it, the radial shockwave for the bone and the tendons, the range of motion was normal after 3 treatments, means 10 days. The MRI check after 5 treatments, I show you the pictures, was perfect. There's nearly no bone marrow edema anymore, and that correlates to the fact that he was pain-free. And now, of course, they get some more. They get the insoles, and they can start running and doing physio anymore still, or again, and do special strengthening training, because after 4 months or 5 months without training, the muscle is not so strong as it was before, and that's why they do a lot of specialized stabling training to strengthen it up. And at the 5th of July, he was back on the field. So we call the return to competition. The RTC time was about 2 months after we started the treatment, and he was suffering 4 months before without any result. The next case is a goalkeeper, an ice hockey goalkeeper at the German second tier club. He had a partial rupture of his left medial collateral ligament, which is horrible for a goalkeeper in ice hockey, because if you can see it here, they always do this butterfly movement, which is the most worst thing that you can do on your medial collateral ligament. And if you have any injury on these ligaments, it is really horrible for the goalkeepers, and for some of them, it's the end of their career. So they did a lot of physio and stabilization training with him, and it started to be good in the middle of February, 2 months later. But then he did some exercises for a goalkeeper, like, for example, these butterfly movements. And then he had a complete rupture of the medial collateral ligament. And he was unstable, he had a lot of pain, and of course, he worried about the future. Then they planned surgery because it didn't get better by its own. But he didn't want to have surgery. So he came to my practice and said, can we do anything else? So we did the GDT program with him, means we tried the laser, but the laser was only at the beginning, very important, because with the laser, the pain goes down and you can start with higher pressure, and that's what we did. We only used the radial shockwave. It's absolutely enough in this cases, and treated the medial collateral ligament every 3 to 5 days. And after 8 treatments, after 3 weeks, we went to once per week. And from the second treatment, we also treated the left tractus, the iliotibial tract, and his myoglosis that came up in the time after his rupture of the ligament. And after these treatments, after 5 treatments, we could start with him to do strength and stability training again. And as you can see, we started at the 7th of April, and at the 17th of May, he was completely painful. He was full stable and had full range of motion, and could start with his normal ice hockey goalkeeper training again. And as an addition, he had a muscle tear at the 9th of September, and that was 2 weeks before they start with their season. So we treated the muscle, of course, too. And after the treatment of this muscle tear, he could really start at the 24th of September with the season. Normally, he was pain-free, and he was the regular goalkeeper for the whole season. I think this is really impressive, because for a lot of goalkeepers, such an injury is normally the end of the career, as I said. Here we see another muscle fiber tear, but this is not so common. The muscle fiber tear of the tensor fasciolate muscle at the beginning of the hip. This is, in this case, it's a 15-year-old track and field athlete, a top athlete in Bavaria. It's the south of Germany where we live. It's a big area, and he's one of the best through all under 16 guys. And he had a shooting pain during running hurdles, and that's the typical kind of the way you get the injury in the tensor fasciolate muscle. He described it as at the pelvis above the left hip. It's exactly where the tensor fasciolate muscle starts, and there was the biggest pain. He had to give up immediately. He was doing the Southern German competition, very important for him, but he couldn't do any more because the pain was too excessive. And he also had, that's what he told me when he came to me, he also had a recurring typical shin splint problems at the front of his, you have the calf on the dorsal side and the ventral side. We call it shin splints. The pain was when he was doing his competitions, the pain went up to 8 to 9, and he had to cancel some competitions over the last 2 years. So what we did an ultrasound to see the muscle fiber tear, and he had a hematoma of 10 to 4 millimeters, exactly at the point of most pain. So it was clear that this was a real tear. So we started the treatment with 1.4 to 1.8 bar at the tensor fasciolate muscle. And we used cryolite, that's an hyperbaric cooling therapy. For us, very important to get the pain down. And in addition, we also worked on the shin splints. We had to start with 0.4 bar. You can do this with the old or older classic EMS device. If this is not possible, you can also use the cryolite or any other kind of cooling therapy for a few days, or if you have also a laser, of course, to get the pain down. If the pain goes down, then you can start with, I think, 1.0 bar or 1.5 bar normally, but in this case we started because we had the possibility, we started earlier and with very low bar. After the third treatment, he felt much better. The light training that he did after 3 treatments, we're talking about 3 treatments, was successful. There was no pain anymore. We went up to 2.7 bar with the shockwave therapy on the muscle fiber tear. And also 1.5 bar on the shin splints, and then he went back to full training after this third treatment. We treated him for the next weeks too, about 4 or 5 weeks, when he was increasing the load in his training. But for the last 2 years, as he said, it was the first time that he was pain-free on the shin splints, and of course he had no more problems with his muscle fiber tear of the tensor fasciolate, which is really, really impressive. And because it is so impressive, he sent us pictures from the next competition that he had. It was the under 16 Bavarian Championship. Bavaria is the biggest part of one of the biggest parts of Germany, and he was starting as a 15-year-old, so was younger than all the other guys that were 16, and he won the first place in 3 competitions, the first place in 2 times, and once he was the second, and this was about, I think, 1 or 2 weeks after the last treatment. So this is really a success for the treatment with shockwave. As Alex told you, we have one really big wound, and want to show you the wound healing that is possible with shockwave. This is a friend of mine and the thigh of a friend of mine. He's a really good sportsman. He's 41 years old, but still, or he was 41 years old, but still playing football, doing marathon, really fit guy. And he fell off a ladder from 2 meters. That was no problem for him. He landed on his feet, but there was a metal standing out of the ladder, and the metal cut his thigh. As you can see, very, very, very deep. He was very lucky because the vessels and the nerves were not touched here, but I think it were about 1 or 2 millimeters. He was lucky concerning this, but the whole muscle was cut. And you can see it here. This was the picture before they began surgery in the hospital. After the surgery, that was done by a really famous surgeon in Augsburg, and it was done really good, but he got a wound healing problem afterwards, and inflammation. And as you can see here, it got worse and worse and really terrible. And when it looked like this, they told him they can do in the clinic, they can only now debride the wound, leave it open, rinse it, and wait until it gets better. And after this, they told him to do a muscle flap operation, a muscle flap transposition, they call it, and maybe in 1 or 2 sessions, a skin graft afterwards. And they told him that the total healing time, if everything works well, is 6 to 12 months, depending on the speed of the whole healing progress. And the worst thing for him was that they said it's possible to have restrictions later on when he was doing sport, so that the muscle could be so affected that he couldn't do his sport anymore or in the way he does it. And it was terrible for him. And he told me, and he left the hospital to have a talk to me, and he asked me what we can do. And we have to tell you that in this case, this is something that is normally contraindicated because we have bacteria in this wound, I think. We have really a wound that is nothing that you would normally try to treat with anything else than surgery. But in this case, he had a double antibiotic therapy. He had the chief of the department that did the surgeon the first time, that operated him for the first time, told him that he can have his mobile number and call him. And every time when he says, "Now I want the surgery," he comes into the hospital and does the surgery. So we were really secure, I think, with this, and that's why we started shockwave therapy. Now I want to show you what happened after 8 weeks. We did it for 8 weeks, 10 treatments. I had to do necrosectomy to get the necrosis zones away for 2 times after the first and the 4th treatment. And after 10 treatments, this is what you see now in the video. This is exactly what is the result of what we did. What I want to show you in the video, it's not so important because I'm telling in German, but what I show you in the video is how good the tissue gets, how soft the muscle and the tissue is, and how much pressure I can put on it, and how strong the little scar that you can see is.
Handelt sich um eine schwere Rissverletzung, zusätzlich 1-2 Behandlungen bis Ende des Jahres, um diesen Zustand zu lösen.
Okay, and what you can see is that the scar is on the one hand strong. I can really put pressure on it, but it's also soft, and it doesn't make any pressure on the muscle. The muscle is soft too. And the guys in this, when we do this video, he went for running 3 times in the last week, 8 kilometers per run, and had no pain and no problem. And he's doing marathon and playing football again now. We change again.
Probably one of the most common injuries in all kind of sports or in normal life is the acute ATFL rupture. In this case, it was a professional football player suffering from an ankle distortion during a season game. In the ultrasound, you could see the ATFL rupture. We had a massive joint swelling, and of course, consequential injury of the joint capsule. Acute treatment within the first hour, which is quite important to do, is the high power laser or cooling therapy of all kind and cooling compressions. After 12 hours, we already start with a shockwave in combination of laser or without, doesn't matter. We start with a radial shockwave, 0.5 bar, 20 to, with the newest device, 25 hertz frequency, a lot of impulses, 5,000 or even more, depends on the swelling, and a cooling possibility afterwards. Then after 24 hours, this is an effect we see with almost all of these injuries. Walking with full load is possible, painless, no swelling anymore. In this case, we did the MRI 1.5 days afterwards. Also, so we already treated the injury. There you can see the ATFL rupture, of course, but what we see is that there's just a slight swelling of the joint left. So treatment was really effective already. On the pictures, you can see how we do the shockwave. The first picture shows the cooling device. Then we see the application with the 15 millimeter applicator directly on the ruptured area. We did laser and daily shockwave up to 3.0 bar. And some additional things, of course, or manual techniques we have. We have a fast increase of the load, which is also just depending on the pain. And then after a total of 19 days, we had a return to competition of this football player. And this is a number 15 to 25 days, depending on the reaction of the ankle, which we reach with almost all these ATFL ruptures. Another case, this is a professional tennis player suffering from severe inflammation of the inferior ramus pubis. On the pictures, you can see the MRI results after already 7 weeks of rest. So this player wasn't doing any sport 7 weeks in total, and this is the result in the MRI. You can see a severe lighting inflammation in the pubical bone. The pain became more and more pronounced the last 7 weeks, even during normal activities without doing any sport. He also got physio, pain medication, cooling therapies, ultrasound, osteopathy, and all these kinds painkillers. Then we started with the radial shockwave therapy of the pubic bone and the abductor muscles and the entire back. The first treatment was just with 1.3 bar because it was just so painful. Then we did the therapy every 3 days in combination with physio. Every 2 days in gentle shear therapy in the thoracic spine, lumbar spine, sacroiliac joint, all these things. We started initially also with a high power laser because of pain or moving quickly, and cooling therapy, which is also always a part of our therapy. As you can see the results on these pictures, we have the first picture on the left was the beginning picture, yeah, with the severe inflammation. In the following 2, 3, and 4 pictures, you can see that the lightning is less a lot. Yeah. That is not gone, it's not important for us because you can see these lightnings rests in the MRI even months after the injury. So which is quite important is that we have a completely pain-free patient. At last, the radial pressure was at 3.6 bar on the pubic bone and the abductors. And 2 weeks later, we had a very important win on the ATP Challenger tournament from this player. So always keep in mind radial shockwave on the injured area, and threshold of the patient during all kinds of training is important, not the MRI picture. So if there's a lightning left, just leave it. A very exciting case because you saw now a lot of cases how to treat patients always on the injured area. I would just want to show you what possibilities are also possible to treat your patients. This was ice hockey goalkeeper, youth ice hockey goalkeeper with external rotation deficit, low back pain in the joint. This was the pre-test, the Patrick signs. You can see on the left picture, extra rotation is on the left is a lot less than on the right side, and it was extremely painful, especially in the lower back and the gluteus medius and minimus muscles. So what can you do? Of course, we can treat all these big areas on the back, on the side, on the front, yeah, to reach a result. But another possibility to get a very quick result is go on the medial malleolus beneath, as you can see in the left picture. Just put 3,000 impulses on this area with a frequency of 20 hertz, around 2 bar, but remain on the threshold of the patient. The idea behind this is to influence the following muscles via the muscle flexor tibialis posterior muscle chain. It goes up over just rough. There are more muscles involved: biceps, quadriceps, adductors, and which is one of the most important muscles is the iliopsoas muscle. So after this one treatment, we have a result like this. Extra rotation on the left and on the right is almost the same. The pain is almost gone in the gluteus medius and minimus muscle, and the lower back, it's with more range of motion, just 2 out of 10. So whenever you have patients with lower back pain, extra rotation problems, hip extension problems, hip abductor problems, this is a very quick and easy way to reduce the pain and the range of motion of your patients.
To the last case, we have to tell you that we are working with this muscle change for years now, using shockwave for treating muscle change. What is very important, we are also working with the trigger points, of course. And I think a lot of you know how to do acupuncture on trigger points. You can also use the points, the acupuncture points, when you're treating shockwave. I think the results will impress you, because in a few seconds you can do a lot of things that you would never expect. That's really something you try. The next one, I'll keep it very short because we don't have the time to do it longer. This is a professional football player of America, in America, from the Minnesota Vikings. And this is typical. He had an upper ankle joint surgery. And after that, the joint got very, very good. And the player was very happy with the result of the surgery, but he couldn't go and go for a run or something. That was the problem of the muscles. So in this case, we saw the guy because he went on holiday to Germany, because his family or parts of his family live here, and I got a call from his team doctor. If we can, I know the team doctor of the Minnesota Vikings for years, and he told me, can you work with the guy while he is in Germany for a week? We did this with our friends in Mainz. Stefan Tröster is working for the football team in Mainz, the first league in Germany. He did shockwave therapy, of course, physiotherapy and osteopathy with the guy. And then he came to me one day before he left back to America. We did a lot of things with his ankle. We worked on his ankle, and we will show you afterwards, if you want, in a live treatment, how you work on an ankle. But what we also did, we worked on the whole iliotibial tract. Here it says tract, that's the German word. That's wrong. It should be the iliotibial tract and the sacroiliac joint. And as Alex said before, we're working with the iliopsoas and all the muscles that can do too strong muscle hardening in the whole chain. So you get an inner rotation of the leg, and that's one of the biggest problems, because all the muscles do this inner rotation, and the guy cannot walk properly because of the inner rotation. And so we did the shockwave on all these muscles. We did some chiropractic on his lumbar spine, the sacroiliac joint, and the ankle. Can do this. It was 6 weeks after the surgery, so you can do all this, the chiropractic that you know from the ankle joint you can do. And after that, we got a full range of motion of his right hip again, his right knee, and his ankle joint. And when he came back to America, he had no more issues anymore, and he could start running, training right away from this point when he landed in America. Here are the pictures, and the funny thing is, in the picture on the left down, there's me and a friend of mine who is a football player from Germany. And you see now why the football players in America are better than in Germany, because they are more than one head higher. The last one, a very short one, is the severe disease. The apophysitis calcanei means a kind of inflammation in the bone of young children. The youngest that we have was 5 years old. This is one of the most impressive cases, because the little girl was so painful. She couldn't even step on the foot for a month. And we start she had no trauma. That's in a lot of cases, it's no trauma that starts when the pain starts. But She had an X-ray that was unremarkable. It's always the same. And she was immobilized, as all the children that I saw before, they're all immobilized in a plaster, for example. And the problem is that the plaster doesn't bring anything. They have no improvement for the next weeks. And I think it's even worse than before normally, because the muscle is getting thinner and thinner. And so we always start shockwave therapy as fast as possible. If we have the possibility with the Dollar Classic to start lower than 1.0 or 1.5, then you can do that. But if you don't have the possibility, for example, with the Smart 20, if you work with 1.5 bar, it is also possible. We will show you a trick how you can do that, but you can also use the time before you start shockwave for about 1 or 2 weeks by cooling it down. For example, if you have using a laser with a pain program, and then get the pain down, and then use shockwave, because if you use shockwave, you have about 2 to 4 treatments. In this case, it was 4 treatments, and then a complete problem is gone. The children can step on the foot, can roll over the ankle. That's absolutely no problem. But sometimes it comes on the second side. We have a lot of cases where this happens because we don't know where it comes from, so we don't know why it is on one side or both sides. But we did exactly the same again, and after 4 treatments again, the patient was completely pain-free. And that's what we want for the children, because the worst case that I had was a football player, 10 years old, and he was suffering for 13 months, and he couldn't step on the foot for 13 months, more than 1 year. And we did 5 treatments, and he was back on the football field. So that's why we want to show you this, because we can help these children so well. Okay. So always keep in mind, when you do shockwave, pain is temporary, glory is forever. That's exactly what we want you to know when you work with your radial shockwave device. Thank you very much. And now we would go on with the questions, and then show you how we treat some things when we know your questions.
Thank you, Peter. Thank you, Alex, for sharing all these interesting specific cases with all these details on treatment protocols. This is always interesting. Always, we can feel the passion from you. So thank you. Thank you. And we don't have any questions. Please don't be shy. Ask your questions if you have any. No questions so far.
Or if you have special indications you want to see how we treat them.
I just want to make a quick comment about the laser. Well, you mentioned that you used also the laser in some of the cases, but the laser, I have to mention that the laser, high power laser dollar class is not available yet in Japan, but we will do our best to have it available next year. So we will keep you informed anyway. I think we have a question.
You have a question, yes, and it's a very good question.
Which place should we put the shockwave for severe disease on the devices?
Okay, we'll show you now. Wait, can you see Alex? Yes, I think you can see Alex.
Mm-hmm.
Okay. Okay.
Do we need to make the picture bigger, or is it good like this?
It's good like this.
Good.
Okay,
Looks
perfect.
good.
So now, can you see the ankle? We don't put the device on because it's too loud. So we just show you where we normally do this. Wait a second.
Mm-hmm.
More space now. Well, it's very easy because, and that's something that is proven in studies, you don't have to put the shockwave device exactly only on the point where we have, for example, the bone marrow edema, or where you have or where you have the fracture, or in this case, the pain in the bone, because the bone is something special. The shock waves work in the whole area around, and that's why it is very, very easy, because you have to put it only on the calcaneus. The epiphysis is on the back, so you can use it here completely through the whole bone. You can use the big applicator, doesn't matter which one you have. You can also work with the small one. The small one is a little bit more painful, so we normally start when we use with children with the big one, because we don't want to have pain in the ankle of a child. Normally we work like a pain from about 1 to 2, maybe 3 on the scale, but not more for children. And then you can really use it on this side, do about 1,500 impulses on this side, then do the same, turn around, Alex, completely on the other side. And normally that's absolutely enough, but you can also do it from down here. And if you have more than 3,000 impulses, that's perfect. About 4,000 would be perfect, normally 4 to 5, I think. And that's something that the children normally tolerate very well, because it's not so painful as you think. And now is the trick that we told you. If it's painful for the patient, do it with a quick movement. The shock waves are faster than everything you can do. But if you move like this on the bone very fast, the children don't, or not only the children, all patients don't feel the pain so much. So this is something that you can do like this or like this, just to hit the whole bone and not the epiphysis. But in this case, the problem, or not the problem, the good thing is that as the same as the Schlatter disease, it's not really very important, because it's more like an apophysis. That's the same as at the Schlatter disease, and that's why the Schlatter disease is an approved indication. I think in a few months or years, it will be the same with the Sever's disease. Good. Okay.
Thank you so much for showing this. Thank you.
If the answer is not good enough, tell us.
We are motivating the troops to ask questions. So please feel free to ask your questions. Any question is interesting.
Yeah, there was an addition to the question, I think. The gastrocnemius muscle is a very important muscle, because of course it's between the ankle joint and the knee. So a lot of problems with the ankle joint or the knee do problem with the gastrocnemius muscle. Or if you have a hardening muscle or a tear in the muscle, you always get problems with your ankle joint or your knee. So that's why we normally, when we, for example, treat the Achilles tendon or the ankle joint or the knee, we always work on the gastrocnemius muscle too. Osgood disease. Okay, that's perfect. I think we can show you where we put the shock wave and how we do it on the Osgood-Schlatter disease. And we can also show you how we use it on the gastrocnemius muscle and, for example, the Achilles tendon. Okay, wait a second. Alex has to get naked.
Alex needs to be the perfect patient for this indication.
Yeah, exactly. Okay. We first show you the Osgood-Schlatter disease place where we use it. And here it's the same. You can also use the big applicator, for example, at the beginning of the treatment. You can start with laying the knee down, or in this position. It doesn't matter what is more comfortable for the child or the young. And we use it normally. This is the point where the apophysis and where the patellar tendon gets in, and then we use it exactly in this direction. Now we start with this because this is normally the most painful point, and then we go around the insertion point. You see all the point. Here is the tendon. Hang on, wait a second. Here's the patellar tendon. You see that here? I always wanted to mark, Alex. And here's
Yes, perfect.
the slab that you see is situated normally.
Mhm.
And we go around this place where the insertion is, but that's very important. We also use it for the whole patellar tendon, because normally if it starts here, it goes up there, because most of the children or young guys who have this are do very intensive sport, and that's why they don't come when the first pain comes. They come when it is painful here and goes up here. And so we work on the whole patellar tendon and around the insertion point. And it's very important to get the pain away. We use a little pain at the beginning, then the pain gets better. That's what was in the summary of the theory. The substance P goes away, so the pain gets better. Then we go up with the load, do it again until it gets better, and then we go up with the load 3 times. That's for us, it's pretty normal to do that. And something you can do also is, when you work on the patellar tendon, also use it for the quadriceps tendon, because in most of the cases, they got a hardening of the muscle here because the pain is too strong here and the muscle gets hard here. So also use it around and go through the quadriceps in the lower part.
To relax the muscle and
to relax the muscle, get the tension of the whole tendon away,
Mhm.
the quadriceps tendon and the patellar tendon, and so get less tension on it, because the tension is the problem why it starts in the insertion point. Here at the apophysis. Okay.
Okay, perfect.
What it says? We go on with the quadriceps. Gastrocnemius. What do you want to do? Gastrocnemius.
What was it, gastrocnemius?
Gastrocnemius. Yeah. Okay. Sorry. We go on with the gastrocnemius. It is so. Okay. Ich kann das selber halten. Leg du die mal richtig hin. Yeah. Can you see? Yeah, I think so. That's.
You can see the gastrocnemius. Yes.
The Achilles tendon is going up here and coming into or going into the gastrocnemius muscle. So when we treat Achilles tendon, we always start with the insertion points. We go through the whole calcaneus. That's very, very important. Because it's not only a problem of the tendon, but also a problem of the bone. Then we go up, and when we went through the whole tendon from all sides, we go to the gastrocnemius muscle and go through the whole muscle. And we also, go through the whole muscle up to the knee, because we know the tendon of the gastrocnemius goes over the knee and inserts here. And that's why we use it from down here, up over the whole muscle, up to the tendon, nearly over the middle of the knee. That's very, very important. And we do it also, this is the lateral part. We also do it, of course, on the medial part. You can see here, and we go up to the knee again and over the point.
Okay.
That's very important. And this is also the part where we normally work, where the hamstrings come down and the gastrocnemius tendons go up. Here is a part where we always work when the patients have problems with stretching the knee. It's always the same. You have here hardening of the muscle and the tension on the tendons here too. And so you can go through the tendons with sometimes with a lot of pressure to get them really free. It's tingling.
Yes.
Okay. And if you do this, and you can also do it in the position we have now, but if you want, you can stretch the leg, overstretch the leg. Can you see that position? It's overstretched now. This is the knee. Here's the Achilles tendon. The knee is overstretched. And then you can go through this in this overstretching position. And after that, normally the patient stands up and says, okay, now the bending is nearly complete. And that's really something you can, with every treatment, you get 5 to 10 degrees back, especially in patients who were had surgery on the knee or a problem with osteoarthritis and have a bending problem. that's really, really impressive what you can reach with this.
Okay. Quick question from my side. When you have some varicosities on the veins on the gastrocnemius, can you provide a shockwave treatment? Or
if you have only problems like there's a swelling because of the veins, then it's no problem. If you have a thrombosis, fresh thrombosis, you cannot do shockwave for the next, I would say it's 6 months. That's dangerous, because if you do that, it's possible that the thrombosis gets up, or
moves, and
that would be not good. So
it's a contraindication anyway. Yeah.
Have the best would be to have, after thrombosis, have a control with your specialized doctor for pain. And if he says no, it's okay, the thrombosis is gone, then you can start again. But all kinds of swelling because of the veins, or like we call it
varicosity. I don't know.
Varicosity. That's it. Yeah.
Yeah. Varicosity.
Normally, if there's no thrombosis, that's no problem.
Okay. Perfect.
But it's not air-filled, you know, it's not air-filled tissue, so I don't care. Yeah, thrombosis is the difference, but normal varicosis or veins don't. I'm not bothered about.
Okay, perfect. Thank you.
Oh, perfect questions. So, what disease do you treat most often? Oh, that's that's not so easy.
To make the answer quick, before we go into detail, we do all kinds of muscle injuries, all kind of bone fractures,
all kind of back problems or the syndromes. It means the cervical part, lumbar part, and so on. We do a lot on the back, I think.
A lot of low back pain is a very common injury we have in Europe, I would say.
Yeah. Lower back pain is one of the most, let's say,
all kind of tendinopathies, especially elbow tendinopathies is quite common. Tennis elbow,
Achilles tendon. I think the Achilles tendon.
This is I would say 80% of everything what we treat. Then we have the special things. Lymphedema, all kinds of lymphedema. It's a very big topic. But then all the small parts you could see in our presentation.
Lymphedema is getting more and more topic because of the tumor diseases, of course. And if they felt it once how good it works, they talk to their friends having same problems and so on. And so we get a lot of lymphedema problems too. Yeah, that's right.
This is increasing.
I think it's increasing because we have more and more cancer diseases.
Yeah, probably.
And treatment options, but the treatment options are sometimes, as you saw before, irradiation and something, and then you get a trauma on the skin, and then you get the lymphedema problem, and so this increases, of course. The next one, what about metatarsagia? Oh, that's very, very good, because you can do a lot of things, especially the metatarsa problems like fractures. What do you call that? Sometimes you have, without a trauma, you get fractures in the metatarsal bones.
Because the bone is getting tired because of the overload of the bone.
We have this in growing young guys. We have this with older guys when they are still fit and doing a lot of things. We have this marathon runners and so on.
Military service is quite common because they need to walk a very lot in the beginning of their training, and then they get these kind of fractures in the foot.
And you can work on the middle foot. I will show that now. You can work on the middle foot from every part. It's nearly the same as the plantar fasciopathy. But when you're working from the plantar side, you're working through the whole plantar fascia and through the bone. Okay. Wait, I show you. So if you have any kind of fractures, metatarsagia means in a lot of cases only bone marrow edema, for example, the so-called Köhler's disease, which is also a kind of fracture that comes by because of the stress and a lot of when you're already busy with your foot. And then you're searching for the point where it's broken. You can go from the plantar side. It's the same with, and you can also start from the upper side. The problem here is that it's in most of the cases it's more painful than from the plantar side. This is normally something you can start with 1.5, 1.8 bar. On this side, sometimes you have to use, for example, a cooling or a laser before, because you have to start with 1.0 to 1.5 bar. But when you can go over it, you will have good results in a very short time. I think most of the patients get better after 3 to 5 treatments. Maybe if there's really something broken or you have a bad bone marrow edema, you need up to 8 to 10 treatments, because this is something in the bone that is really painful and needs time. But you will get a good result for all of them. And for the Köhler disease. That's very funny because nobody knows that you can use shockwave for something like the Köhler. And if you want to treat the heel spur, for example, you start at the point where the most painful part is. You go on until the pain decreases, and then you can go back and have a look where it is painful in the part behind the heel spur. And of course, and it's very important, you have to go into the fascia and go through all of this. And also on the lateral part and on the medial part. And you always have to go through the joints of the toes, because in most of the cases, because of the tension here, you have a pain in all the ground joints that you have at the toes. Very, very important.
How much pressure do you apply on this area? Because it must be very sensitive.
That depends. Normally, I would say you can start with 1.5 bar, but you can really go up to 3.0 bar sometimes if it gets better. It depends on the patient, but I would say starting with 1.5 is okay.
Okay, perfect. Yeah, because for sensitive patients sensitive to pain or tolerance to pain can be very painful and very stressful for patients. Yeah.
But if it's too painful here with 1.5 bar, you can always try with, for example, a laser or cooling therapy for about 1 week. They have to cool it down 3 times a day for about 10 minutes. And then normally it gets better so that you can start after 1 week with your shockwave device.
Can manual therapy help or it's better doing cryo or?
Usually we do shockwave before and manual therapy afterwards.
Exactly.
That's important. Yeah, it's helpful if you do the shockwave before. It's much easier to do the manual therapy afterwards.
Yeah. And also for the middle foot and for the ankle joint. If you go through all of these parts, the ankle joint, we always use 3 points. From the ventral part and from the inner dorsal part and from the outer dorsal part, between the peroneus tendon and the Achilles tendon, you go through into the joint. If you put the shockwave in there and the pain gets better, the patient the capsule of the ankle joint is more soft than before, and then you can do your chiropractic. Exactly the same as for the middle foot. If you do it, as Alex said, in his case, if you do it in this special point here, down here in the medial part of the middle foot, and you do it on the lateral part of the middle foot here, and you wait until the pain goes down, then it's much easier to do chiropractic in the foot. The same as with the ground toes. It's the same.
Okay, perfect. We can do every zone, well, every area of the foot with the shock, almost.
If we can stand the pain at the beginning, then it gets better and better. And we have patients coming up with no problems anymore, but coming every 6 to 8 weeks just to have such a reload of the treatment. And because they say, when you do this every 6 weeks, I have no pain anymore. It doesn't matter what I do in my normal day life.
Okay. What about pseudoarthrosis? Did you?
Which kind of arthrosis? Pseudoarthrosis. Pseudoarthrosis. We know from new studies that you can also treat it perfectly with radial shockwave. And the year before it was said that you have to use focused shockwave. That's nonsense. You can also treat it with focused shockwave. Absolutely, with radio shockwave. Absolutely no problem. Normally, you have the same results when you do that.
Okay, perfect. Thanks a lot for sharing all this. Any
We are nearly
additional-
on time.
Hang on for a second, because I think pseudarthrosis is a quite important topic. I just want to show you two pictures. Yeah. We
Yeah.
don't have them in this part, but I think it's quite important to see.
Alex is showing pictures from his treasure box. Wait.
Because I like pseudarthrosis cases.
Because the results are
so brilliant.
impressive.
The results are impressive.
Really.
Yeah, hang on.
Okay, perfect.
Okay, hang on. It was not planned, so but
No.
it's quite interesting. So,
Improvisation. Okay.
so as you can see on this picture, you see this?
Yes.
Yeah, this is a 8-month-old pseudarthrosis, which we are treating at the moment. After the first series of shockwave, the healing started. I'm still waiting. It's an actual case at the moment, and I'm still waiting for the final result. But this is quite a nice one. This was a young lady. It was the beginning after a planned surgery. You see in the first picture that you have almost no healing after 6 weeks. Yeah, and this is the result on the right side after 5 combined ESVT shockwave therapies after the second 5.
The consolidation started. Yeah.
It's almost closed.
Almost closed.
It's almost closed. Yeah, we see a lot of bone in this area. Yeah, and the line is almost closed. So she's allowed to do everything now.
Wow.
Yeah.
Impressive.
Because it's quite interesting, you know.
If you don't believe it from one case, I'll show you the case of an 18-year-old
And this was with the standard settings.
Yeah, standard settings of shockwave. We only orientate with the pain of the patient. Can you see?
Yes.
Can you see that? Yeah.
Yeah.
This is more than 5 months after the injury and the surgery. He has a lot of pain, cannot walk on the leg. And wait, give me a second. And this is after 5.5 weeks with shockwave.
Wow.
Do you see what the bone does here? Can
Yeah.
you see that?
Yeah.
So this was before. Wait,
Very interesting. The both.
that's really something.
Yeah.
Really something impressive, because if you see that the bone is doing nothing here, and this is an 18-year-old guy, it shouldn't be the case. It shouldn't be like this. And then you see what it does after 5.5 weeks. The shockwave.
You can see the osteoblasts work.
Yeah, you can see what they do, and
Yeah.
that's the cause.
Wow.
I would say we do the last question
Yeah.
to
And then we
come to an end,
because we want to be on time.
because it's a quite interesting question. Yeah, it's just do we need to make dorsiflexion in the ankle when we have a plantar fasciitis? Basically, we are always treating these kinds of all kinds of muscle injuries by changing the position of the ankle, by changing the load of the muscle, go always in different positions. Yeah, because with more tension, we reach different kind of pain receptors, and we always want to reach all kind of pain receptors. So we change it. We just don't do the dorsiflexion. We also do plantar flexion. Yeah. So the foot needs to be in all positions of tension of the fascia or the muscle.
And as you saw before, when I treated his knee, you can always go into a really stretching position as you would do it normally without shockwave, and then put shockwave on it. Because the stretching is very important, but what you can reach with shockwave while you are stretching is unbelievable. Yeah.
Okay. Wow.
Okie doke.
Thank you so much. And patellar tendinopathy, well, to get the patients to flex, well, it's the same thing to the same question. Okay, thank you everyone. We have Yeah, thank you everyone for your participation. We will close this session now. Thank you again, Peter and Alex. It's always a pleasure to be with you and to see all these cases. We want to know more each time. So, so we are looking forward to the next one. Thank you so much, everyone, for your participation. The next webinar will be scheduled on Tuesday, the 29th of November, same time, 7 p.m. for you in Japan and noon for us in Europe. Thank you again. Stay tuned, and you'll be able to register for this webinar this week. It will be online. So thank you again and see you next time online.
Bye-bye.
Thank you, Emedik and Yumiko, and thank you all. Bye-bye.
Bye-bye.